Dear Chairman, thank you for the invitation to present at the 2021 EBC meeting. The title of my presentation is Anatomic and Flow Characteristics of LAD Lesions Predisposing to ST Elevation Myocardial Infarction. I'm happy to present these results on behalf of my co-authors shown here, and especially want to recognize Dimos Kastridis, who designed and led the research. The results have been published previously earlier this year in the American Journal of Cardiology. By way of background, we know that myocardial infarction occurs more frequently at sites of moderate stenosis, although this may be a denominator issue with many more of those lesions present. We also know that culprit lesions that progress to myocardial infarction are not uniformly distributed, but tend to cluster at specific anatomic regions. Our objective for this study was to test whether we could identify lesion, anatomic, and flow characteristics that would be associated with subsequent ST elevation myocardial infarction involving the left anterior descending coronary artery. We then hope to develop a lesion risk score to test for prediction of future risk. We began with paired angiograms from 90 subjects who presented with LAD STEMI and who had had an angiogram within the prior 6 to 12 months. Within the LAD, we identified corporate lesions as the site of eventual occlusion, and other lesions within the LAD were considered to be stable lesions. The subjects were divided into a derivation cohort, including 200 lesions and 61 subjects, and a validation cohort of 95 lesions and 29 subjects. The angiographic analysis and computational flow dynamics were performed using 3D reconstruction algorithm by the Coronary Flow Research Unit at Hygeia Hospital in Athens. The angiographic parameters of interest are shown here on the left and included stenosis severity, distance from the LAD ostium, lesion length, distance from a bifurcation, lesion symmetry, and computational flow simulation. Our goal was to develop a logistic regression model of the significant angiographic predictors, first in the derivation cohort, with an optimal threshold determined using ROC curve analysis for each of the significant angiographic parameters. We then developed an integer score based on the model coefficients and tested the proposed score for prediction of progression to a culprit lesion and eventual STEMI. In terms of the baseline characteristics, not unexpected for a STEMI population, the patients were relatively young. They're mostly male. Only about 20% had diabetes at baseline. There's a rather high incidence of current smoking in 36% of the subjects. The time between the baseline angiogram and the eventual STEMI was about 7 months. And in addition to the culprit stenosis, there were approximately 2.3 other lesions in the LAD considered as stable lesions. There were significant difference between culprit stenosis and stable lesions. The culprit stenoses were more severely stenotic. They were much closer to the LAD ostium. They were slightly longer in length. Importantly, nearly 90% of the culprit lesions were in proximity to a bifurcation, in addition to those that were close to the LAD ostium. The lesions tended to be more symmetric, and they were slightly more angulated than the stable stenoses. To look at a couple of the most important parameters and look at the impact of stenosis and lesion location, over 70% of the culprit lesions at baseline were greater than 60% stenosed. And again, over 70% of the lesions were within 40 millimeters of the LAD origin. The results of the multivariable model are shown here. The most significant predictors were diameter stenosis, at least 55%, distance from the LAD origin less than 50 millimeters, and proximity to a bifurcation. We found that a score greater than 10 was the optimal cutoff based on ROC curve analysis, and the results were confirmed in a validation cohort. As shown here on the left, the area under the curve, both for the derivation and the validation cohorts, was greater than 0.9. And if we look at lesion score as a predictor of eventual culprit stenosis, there's an exponential relationship with higher score, a much better predictor of eventual culprit progression. I want to look at just two examples of computational flow characteristics. First, in a moderate stenosis of about 50%, and then in a more severe stenosis of 90%. Shown here on the left is a culprit lesion identified because of its proximity to a bifurcation. And we see even with a rather moderate stenosis, there is flow recirculation at the origin of the side branch, predisposing to eventual thrombosis. If you look at a stable lesion defined by its distance from the bifurcation, the same moderate stenosis has no effect on flow recirculation and maintains laminar flow. If we look at the more severe 90% stenosis, again in the culprit lesion, proximal now to a bifurcation, we see flow recirculation both in the side branch as well as the main vessel, again predisposing to a subsequent state for thrombosis. In a stable lesion with a 90% stenosis quite distal from a bifurcation, we see the flow is maintained mostly laminar, although there is some slight recirculation in the distal vessel. So in conclusion, baseline angiographic parameters of stenosis severity, distance from the LAD origin, and proximity to a bifurcation are significant predictors of subsequent LAD STEMI. There are, of course, several limitations, including this is a retrospective analysis beginning at the point in time that a patient presented with STEMI. And of course, the findings are restricted to the left anterior descending coronary artery. I thank you for your attention and look forward to any questions during the discussion if time allows. Thank you.